Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by Carium, the telehealth platform enabling healthcare's digital transformation, helping you care for people within the fabric of their daily lives. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Steven Cutbirth, Head of Marketing and Brand Strategy at Point Health. Steven, welcome to the show.
Hey, Matt. Excited to be here.
So, Steven, it's great to have you on. And what I always like to do before getting into the main part of the conversation is to let my guests give a little bit more of a background as to who they are and what they do. So the floor is yours.
Awesome. Well, I listened to a few of the episodes, and I know the routine, so hopefully I can follow in the footsteps of your great prior guests. So I'm Steven Cutbirth. Background on me, I literally grew up in healthcare. My dad's a dentist. My mom was the office manager, and I was the kid in the back who came out and played with the kids who were in the waiting room. So that was my job. Maybe filed a chart or two every once in a while. But so grew up in healthcare. Went to business school up in Waco at Baylor, and then after that ended up really through a few things, did an MBA program and got my first job in Austin at a company that is now called Digital Pharmacist, and they help independent community pharmacies kind of compete with the Walgreens and CVSs of the world. So it was a fun first job. And then to fast forward a little bit, now I work at a company called Point Health, and our goal really is to make healthcare easier to find, easier to understand, and easier to afford. And that's what we're trying to do. And we do that through a couple of things. What it looks like is a healthcare navigation service, a bill negotiation service, and then a mobile application that we're building out. We all together call that our smart healthcare platform. And our goal is to launch an app that will allow patients to look at pricing in their area, procedures, look at doctors with an integration on pharmacy costs. Help them identify hospitals in their area, really make it just, as I said, easier for a patient to find care that fits their needs. And we've been going about that for about a year here, and I'm really enjoying it. So it's been fun.
Yeah. So kind of as you just gave the background of it sounds like you're very much focused on I think some of the key topics right now of kind of sounds like individual activation and individual engagement. Before we actually get more into that, I'm just curious. As you said, you kind of grew up in healthcare. So what inspired you to just stay in it? Because I feel like also being, a child of a medical household, without actually going into practice, it seems like there's some type of a drawback in, because I've got other friends who have similar stories.
It's funny. My dad is a dentist. His story is crazy how he even became a dentist. He actually was working at a chemical plant, and he made a mistake and got fired, and then was like, I think I'll be a dentist. And, went to school and became a dentist, which nowadays you could never do because it's so hard to get in dental school. But I grew up kind of in that world, and I liked it. Like, my dad helped people. I always thought it was cool what he did, and I valued him, and he was, seen as like a pillar of our community in a small town, Texas. So I was always a fan. But, my dad, we talk about this now. He actually said, he was like, don't be a dentist. Because if you're a dentist, you have to sit in the chair and do the work all the time. You need to go into business, and then you can, have people work for you. And I was like, that's a good idea. And so I went to business school, and then, in business school, I kind of gravitated towards marketing because I don't know, I wasn't good at finance, I wasn't really good at accounting. Economics was fun, but anyway, I ended up in marketing. And so, after having done that, doing an MBA program, I was kind of like, okay, well, now I need to get a job. But I kind of had this pull toward healthcare because I had grown up in it, I knew it. But I wanted to work in tech as well. Like, that was something I was always, I want to work at Apple or something like that. And so I think what ended up happening is I was able to find a job that married the two. I was able to find a startup tech company in Austin that was helping people in healthcare. And I think, kind of have a bit of a moral compass, where I kind of like working in healthcare because I feel like I can make a difference. And so really it just kind of pulled the three together, like all of those things culminated in that role. So yeah, man, It's funny. I'll say this too. My sister's in dental school. She graduates next year. My brother's an undergrad. So we kind of just all ended up in the whole healthcare world, and we're a healthcare family, I guess.
Yeah, no, that's very interesting. It's actually one of my oldest friend is kind of in that same boat where he's one of three kids. Both his parents are doctors. Both of his siblings are doctors, but he's in the consulting business where he's consulting in healthcare, but he's the only physician in the family. So it's kind of a similar path as you're describing for your family.
Well, it makes for interesting like family gatherings because my dad and my sister will be talking about like, well, the bicuspid molar really needs an M2 joint because if you did this, and then my dad will like try to explain to me what they're talking about. And I'm like, it's okay, it's cool.
Yeah, no. At some point, you're like, I'm happy with the degree of knowledge and focus that I've got.
I don't like blood either. That's the other thing is I don't want to like be dealing with blood and stuff in the mouth, and that doesn't sound like fun. But anyway,
yeah, no. But, it's kind of as you were saying, it's all different forms of being able to help people, and it's I think as you said, just finding kind of that aspect of healthcare is just such a common observation that I hear from everybody working in healthcare. But kind of coming back to I think what you were talking about and referencing, it's kind of how are you seeing individuals being more engaged within their own healthcare journeys, and what are some of the strategies that are enabling and promoting that outcome to occur?
Well, I think there's two like foundational things that are happening. There's many more than that, but I'll hit on two. One, there's been a trend toward higher deductible models, coverage that puts a patient in a position where they have more out-of-pocket cost. They have some people like to say they have skin in the game, and it's led to patients realizing if I go to that facility and that MRI is $5,000 and my deductible is $7,000, I'm gonna have to pay for like a large chunk of that MRI. If I go to this one that's $400, wait a minute, I only have to pay $400. I should do that. So it's just kind of like a common sense, financial incentive for patients who have higher deductibles. And I was one of those at my previous job. I worked at a healthcare agency, and I think we had like a $5,000 deductible, which is not an insignificant amount of money. So I think there's just a financial trend that's occurred, and there's lots of reasons why that's happened we don't have time to go into now, but that's one. I think another thing is you're seeing more and more in, whether it's, the NPR Bill of the Month or Kaiser Health News or the New York Times or Wall Street Journal or whatever, the media is covering how patients are being treated more. And I think that it's just brought more awareness to the general population that in many cases, patients are, I hate to say it, but they're getting screwed sometimes, by healthcare and by hospitals and insurance companies, and you name the player in the industry, but it's just become more commonplace to understand. And I bet if you ask 10 people, 8 of them, 9 of them would know someone or have a story, of a relative who got stuck with a big bill. And that just kind of naturally lends itself to say, next time I'm in that situation, I'm going to think and be a little bit more engaged in the decision I make.
Seeing kind of the common sense behind that, what are some of the ways that people can be able to actually follow through on that kind of new end goal? Because I think it's still, while there might be the feeling of, saying, I'm recognizing that there are all these costs and I'm actually more responsible, there are still, I think it should be well known, a lot of barriers to being able to effectively protect yourself or effectively, make good decisions.
Oh, there's a ton. And not to be cynical, but some of them are put there on purpose, but yeah, there's a ton of barriers that exist in that industry. And I think that's it. Like, it's hard. And if you're a patient and you're sitting in a situation where you need to take your kid to the doctor, and whether it's an emergency or non-emergency, it's hard to make some of those decisions. And I think there's a certain feeling of helplessness when you just don't know. And you're like, where can I find the information? It's not out there. There's no, very little information available to me as a patient to know what decision to make. It even happened with my wife on her ultrasound when she was pregnant. Long story short, we ended up getting charged like $600 for the ultrasound that should have been $200. $400 isn't going to, bankrupt us, but that's frustrating. That shouldn't have happened, and I know this stuff. I should have been able to stop it, but I wasn't able to. And my wife felt, like shame in it. And she was like, well, she was frustrated because she's like, I should have known, but this is what happened to the patient. So all that to say, like, yeah, it's really hard. The information's not out there. In many cases, hospitals don't want it to be out there. And I'm not trying to make hospitals a bad guy. I have lots of friends who work at hospitals. I used to work with them. But if you look at some of the recent stuff that's come out with price transparency for hospitals, in some cases they've blocked Google from searching the pages that have the prices on them. They're very, very rarely put out there in a way that they're easy to navigate. Normally they're kind of hidden in like the footer, or I think ProPublica, someone did a study and it took 10 plus clicks to get to the pricing page. And so most businesses, by the way, it's in the header. It's like pricing. You can go in there and say, okay, for that software it's this. And so I just think there's a lot of barriers. I think it's really hard. And so that's what we're trying to do, honestly, with our company, is we're trying to take that hidden information, organize it in a way that it's actually helpful, and then present it to a patient so they can make an informed decision with information. But there's tons of nuance there. Like, is this a bundled care? Is this an all-inclusive price? Or is this the price at Seton is different than at, Texas Free Market Surgery Center in terms of what they include. Like at Seton, you might also get the anesthesiology bill, and you might also get, the whatever bill. And so it's really hard to show it to patients.
Yeah, no, I think you're dead on in terms of, the difficulty of figuring out what exactly is covered by a particular charge. And, as you said, the different settings of where the care might occur is going to influence what it is, whether it's, inpatient, outpatient, ASC, or, any other kind of combination. But, I think one of the interesting points that you're implying is, and hopefully I'm not going to mischaracterize it, but with the potential scope of information, along with the, let's say, less than ideal ways of being able to get at it, it almost feels like you're going to need kind of third-party intermediaries who are going to help pull all the data from the health care delivery or other organizations within healthcare, and then be able to help run it through all the different probably analytical pathways for easier presentation to individuals.
Because it's so complex, there's no one silver bullet that's going to solve it all. To give you a little background, part of our company Point Health is we acquired and kind of were born out of a partnership with the Caris Group, which is a company that's done bill negotiation and healthcare navigation for 25 years. And so, with that model, it's a human-driven model. It's people. You call in, you say, hey, Justine, I got this bill, what do I do? Or, hey, Justine, I need to get an MRI, what do I do? Where should I go? And our advocates would help those individuals. And so that's still there. Like, you still need that human-driven piece for folks who aren't able to access the information through like an application or a platform. So I don't think that goes away. I think what you have to do is you have to meet people where they are, and if they prefer to use an app to find pricing, do that. If they prefer to call a person, give them that option. If they prefer to send an email, if they want to submit a form on the site, you just have to meet them where they are and give them options to find the care that they need. And yes, to your point, gathering all of that information and displaying it in a way that's actually usable and helpful. It's incredibly challenging, and there's lots of ways you can do it with machine learning and data scientists and algorithms and things to pull that information together. But there's no one easy solution. It takes a ton of work, and our CRO likes to say you're chopping the wood. It's like we're chopping the wood. It's hard and it takes time.
Yeah, I feel like that analogy of chopping the wood applies to so many different aspects of healthcare. Which I think just keeps going back to the point that you keep making, which is there is a lot of complexity, and arguably there's a lot of incentive, long-standing incentives built into the system that don't align with efficiency. I'm not going to say not higher quality, because I think everyone, I think if you talk to any clinician, they're always looking to deliver high quality care, but it's more that efficiency and the cost effectiveness, I think, are not always incentivized within the traditional system.
Yeah, what's the word? Is it the payer agent or the provider agent? The problem you have essentially is that and you've heard that the person paying for the care isn't always the person receiving the care. Well, and I don't like that analogy, because the patient's paying, the employer's paying, but when it comes to the point of service, the patient's often not like pulling out a $100 bill and passing it over. That claim is going to their insurance. The insurance is going to cover the claim, but that creates an issue where the person receiving the care isn't incentivized necessarily to understand the care or the price or shop and all. So yeah, it's just led to this ballooning situation, and this isn't new. People have been talking about this since 20 years ago. It's just no one's figured out how to stop it or try to address it.
Yeah, no, and I think that's a good point, where it's the system's kind of been allowed to continue along the path that it's been on for so long. And for those of you just joining, I'm talking with Steven Cutbirth from Point Health about so far we've been talking a lot about individual engagement, and Steven, we're just starting to talk about how the system is set up and how it hasn't traditionally been kind of centered on encouraging the best decisions to be made. And we've talked in the past about the industry transitioning to value-based care. So are you seeing, what are your thoughts in terms of how that can help change these incentives and maybe align better with what we were talking about in terms of more informed individual choices that are going to, provide probably more financial benefit for individuals, especially, as you were talking about earlier with, high deductible plans becoming so commonplace.
Yeah, I think value-based care is a great thing. I should note, and I have to be careful here. So I did a program at UT that was a Masters of Healthcare Transformation, and we had a wonderful leader, Dr. Elizabeth Teisberg, who I just love and adore, and she's wonderful. And I don't want to screw this up because I want to make her proud. But basically the way they taught it to us was that the value equation is essentially the change in health outcomes for that person and their family over the cost of the full cycle of care. And so, absolutely, if you're a patient looking to receive positive changes in your health outcome, you want to do that in a way that is going to be affordable. And she would talk about, if someone came in, with a knee injury and they couldn't go on a walk and they really loved walking, and you're able to fix that knee injury, like you really improve their outcomes and you improve their life. But if that cost them, and this is an exaggeration, $200,000 for whatever reason, did you help them? Like, you help them in terms of their ability to walk, and that's a huge quality of life issue. But if you now put them into a position where they're in debt the rest of their lives, or they can't afford that, they have to file bankruptcy, are you really helping them? And so yeah, I think those factors have to all be considered. But to kind of go back to what you were asking there, I think the idea of value-based care is so important. I think models that adopt it well, moving away from and I'm going to say this, everybody says it, fee-for-service system where everything is like XYZ has a cost and you add them all up. It's needed. I mean, those systems incentivize doctors, and again, I'm not trying to make them the bad guy, but they incentivize everyone to figure out how to maximize your revenue per unit of per unit of care delivered in a fee-for-service system. And I think the idea of a value-based model that's more about like, did you help that patient here? And whether it's capitated and here's $1,000 a month and keep that patient healthy, and there's upside and downside risk and all that stuff. I think those are good things. I think the industry's there's people smarter than I can talk about this, but I think they've maybe been slow to adopt it because anytime you're changing your revenue model, that's kind of scary. And so I think it's there's been some challenges to adopting it, but I would love to see it more. I'd love to see more patients put in positions where they're able to receive true value and care at a price that is a fair value, not be forced to go to a situation where their health issue was fixed, but now they have a financial issue.
Yeah, no, I'm really intrigued by that definition because it's, if I'm understanding correctly, it's, I think you were saying taking more of an individual by individual approach of determining what is valuable to this individual, by, I think you were saying the impact of the outcome connected to the cost to them, both immediately and long-term, which really seems like it's folding in kind of social determinant of health factors because you're trying to look at it more holistically. So I guess the first part, is that a fair way to be thinking about it?
I think so. And so the model that Dr. Teisberg and Scott Wallace kind of taught us was, as I said, the change in health outcomes over the cost of the full cycle of care. And then the kind of model they put around outcomes was really the 3 C's is how they called it: capability, comfort, and calm. And if you Google that, Dr. Teisberg, comfort, capability, calm, value-based care, you'll find lots of articles they've written on it. But they're trying to, I think, measure outcomes not just in, did you check these 7 boxes that like Medicare requires you to check, but more after that patient, went through care with you, are they now able to, is their capability improved? Can they do what they couldn't do before? Comfort, is their comfort improved and they're living a better quality of life? And calm, can they move forward in a better place? And so if you read her definitions, she'll do a much better job than I will of describing it. But I like that idea of trying to define it in that way.
Yeah, no, and that definition, naturally leads into the second part of what I was thinking about. And I think you already alluded to it, which is it's not necessarily a check the box approach to did you hit these particular quality measures? Because at least to me, it often feels like discussions around value-based care models then go to establishing quality measures and having to show that you were satisfying these different quality measures to be able to show that you're giving higher value care, which probably is not the case in a lot of instances.
Yeah, I think so. I mean, that's always the challenge is how do you measure quality? But yeah, people have talked about patient-reported outcomes and things like that to try to understand how to, and there are lots of great platforms out there to help with that too. I mean, you've probably talked to some of those folks, but some of the models that allow you to really measure if you help that patient or not, more than just, I checked these seven ticks off the requirements.
Yeah, and I think it's, arguably, trying to focus more on, what outcome and how did you change it and how is that, again, going back to that definition of how is that compared to the full cost of care. I think as we're probably both saying it, that's a lot more challenging to be able to define and quantify when it comes to dollars and cents. But at the end of the day, theoretically, that should result in everybody feeling better, because if you can, it argues in favor of having more of a bundled approach or a capitated approach, as opposed to trying to say we're going to incentivize you to do these certain quality things, because maybe trying to hit that standard quality measure is great for one patient but detrimental for another. And if you're just being held to that one standard, it's going to look like you're all over the place, even if your patients are doing better.
I think so. And I'm a fan of, bundled pricing and direct contracting and anything that makes it less complicated and, clearer and simpler for the patient and the payer too. I mean, whichever party you want to focus on. And even the doctors. I mean, gosh, you talk to doctors, they hate dealing with all that stuff. My dad's got a whole, person who just deals with insurance all day long and, they can't stand it. I don't know if I joined a direct primary care practice here in Austin. It's called Euphoria Health, Dr. Chris Larson. It's awesome. My wife just joined it, and it's essentially a monthly fee, and you just pay, I think it's like $70 a month or something. And if you need care, you just message them, and you don't have to worry about it. All the other stuff, they don't file insurance. They keep a really lean system, and so I think that's a model. You and I have talked about like disruption and things like that. I think that's a model that's moving to disrupt a traditional the way that primary care has become to be delivered. Like direct primary care is a way to disrupt that. And I actually saw a stat that said, I think it was for the first time ever, less than 50% of primary care practices are owned by physicians. They've all been bought up now. More than half are bought up.
Yeah, no, I saw that same thing. I think it came out of the from the American Medical Association. That as you're saying, that it was, we're recording this in early May, and I think it was this week that it came out that it was over 50% of physicians are employed by non-physician-owned practices, and so it's kind of interesting because combining that with what you were just talking about with direct primary care, it would be great to get your thoughts in terms of how do you think the disruptive lessons from that model could potentially be extrapolated across the system, because I don't think DPC is going to be a solution for the system, because if you try to do that, you're going to need like many more physicians than are currently being trained to go into primary care. So combining that along with the fact that fewer physicians are running their own practices, and I think the piece that gets lost is not only are they not owning it, but their happiness is also not increasing, because employment by a system comes with its own headaches.
Yeah, well, Dr. Larson, I'll answer your question, but Dr. Larson, he's become kind of a friend. We message and stuff, and he was telling me, he jokingly described himself as like Dr. HR, janitor, billing, accounting, front, he had a lot of slashes in his name, not just MD or DO or whatever. Which is hard, right? Because then, the doctor has to do far more than they might do in another situation. But there's a level of ownership there. There's a level of, like, if I need to make a change, I can just do that. I don't have to go through this whole system to make it happen. So I think there are benefits to doctors who decide to go down that road. Your question, though, is, it's you asked the right question. It's the $1 million question. How can you scale DPC? And I think, Dr. Larson and others are thinking about that, and they're trying to figure it out because, like you said, patient panels can only be so large. You hit some issues there as you try to grow it. So does that mean you pull in some nurse practitioners or physician's assistants and other caregivers who can operate at the very top of their license? Maybe there's something there, but I don't know is the honest answer. There's obviously a question of like equitability, and I would like to see more people have the option or ability to have the kind of relationship you have with a doctor in a DPC model across the board. Because I can just tell you, my whole life I've gone to traditional medicine in the model we have, and everyone knows this. You get 10 minutes maybe, and you get to talk about one thing. But in my experience with more of a DPC model, you really get more time, and you can. There's more flexibility there. And so, yeah, if we can scale that, man, we could be rich, because we need to figure out how to do it. And so, if any listeners know, like, let's figure that out, because I would love, and even beyond being rich, I think you'd be able to help a ton of people get access to a better model.
Yeah, no, and I agree with you. That's kind of that $1 million question, because it's, with the churn that you see in patients in a daily, kind of schedule for physicians. The physicians aren't happy with that because they want more time to be able to interact and not feel like that's rushing. Because the training there is, and I hear this from my wife, who's a primary care physician all the time. It's if you hear something, you're going to talk about it. But then all of a sudden you're 30 minutes behind, and then that impacts everybody else, and you feel bad for them. So it's just this cascading effect. But the problem also is and I think this was kind of maybe going back a little bit in our conversation, but it was a selling point for value-based care a few years ago, which is, there's not that pressure to have to turn through patients because you're going to get a capitated payment in some of the models, so you don't have to turn through. But at the same time, the bigger practice groups are like, well, we need more patients now because we need to get more of that per member per month payment. And the bigger your panel is, the more likely it is that people are going to want to come in, so you have the same problem.
Yeah, I think that's true. And like Dr. Larson, they added a second doctor. His wife's a doctor, actually, so it worked out well. So they have two. They're both now in the practice with him. And I know for a fact that they've been looking to hire additional ones. And I think that is you start to hit some of those growing pains, and then you have to figure out how do you solve them. And again, is it bringing in additional caregivers? How do you handle that? I mean, that's hard with any practice that's growing, I think. But I just know that model to me seems like a better model than the model that we've evolved to. And I really mean this, like I would love to spend some time trying to figure out how to make that work. And I think lots of people are, because it's just, as a patient, it's far superior.
Yeah, no, and I think that's a great point. And believe it or not, we're already just about out of time. So I'm going to close with one final question. Just ask, what has you most optimistic about healthcare right now?
I mean, it's conversations like this, and we do a podcast at Point Health as well. And every one I end up feeling a little bit depressed at one point in time in the conversation, because I'm like, geez, everything sucks. But it's then the like, but what about this? And but what about this? And I ask a similar question. And so it's all the people that are working hard and trying to do something different. It's all the people, the brokers out there who are not just trying to raise premiums every month, but instead work with their clients to set up a self-funded plan and a different model. And it's the health sharing organizations that are taking a different approach, and the doctors who are opening DPC practices, and like all those things that are happening. It's still small, and it has a feel of a David versus Goliath, like the small little folks trying to fight against the machine. But I'm hopeful that those small little folks in the end will be able to make a dent, and that dent will grow, and we can continue to kind of create ripples, because what's the alternative?
No. So, I like that message of, we just got to keep trying and going in different directions. But, believe it or not, we are already out of time. I want to thank my guest, Steven Cutbirth, for a great conversation today.
That's really fun. I appreciate you having me, Matt.
Yeah, no, it's great to have you on. And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.